Can you guys hear me and see my screen?
Yes, we can. Yeah.
Okay, perfect. I'll just pull up my notes. Okay, perfect. So good morning. My name is Kate. I'm a CCFP-EM resident, and today I'll be talking to you guys on my critical appraisal topic, which is the treatment of cannabinoid hyperemesis syndrome. And I came across this topic some time ago, and I was seeing a series of patients that presented with this in a short frame of time. And at the time I was chatting about it with my staff, and a couple of people were mentioning different therapies like haloperidol, capsaicin, or just the conventional gravel. So I decided to look into it and see what evidence was out there with regards to this. The research is relatively new, but I hope that this presentation can shed a little bit of light on that topic. So, no disclosures. And we'll start with the case. So you have this 26-year-old man that presents to your emergency department on your next shift. He's had 4-week history of diffuse abdominal pain, nausea, along with vomiting, every 30 minutes, he says. You look at him and you're a little bit worried, so you get labs. You find out that his sodium is 124, his creatinine is 238, and of course you start IV fluids. You take some more history because you're diligent, and you learn that he's had similar episodes several times over the past 6 years, so this is not new. And he's already seen multiple specialists, had an abdominal ultrasound, a CT abdo, upper G scope, C scope, but still he tells you he does not have a diagnosis. On further history, he also admits to smoking cannabis 4 to 6 times a day for the past 13 years. And he says, interestingly, that his symptoms are alleviated by taking hot showers and baths. So that really helps you with your diagnosis. So of course, in this situation, when someone appears sick and is vomiting, nausea, has abdominal pain, you'd want to rule out the most concerning things. You want to make sure this is not a perforated ulcer, this is not renal colic, this is not bowel obstruction, etc. You do your due diligence, and noting all his previous negative investigations and his cannabinoid use history, you wonder if this could be cannabinoid hyperemesis syndrome, or CHS, I'll refer to in this presentation. So I invite you to think about what you might want to do for his symptoms at this point. It's obviously something that's important to manage in the emergency department, because in this patient, as we already can see, his ongoing severe symptoms are leading to AKI. It can lead to excessive weight loss. It can lead to dehydration, as well as electrolyte abnormalities. So it is important to address. And I invite anyone to post in the chat what you might think if you saw this patient in your next ED shift, what you might be using today. And we'll talk a little bit about the options later in this presentation. So this might be a familiar lineup that you see in your neighborhood. So cannabinoids are the chemical constituents of cannabis, and the psychoactive one that we all know quite well and are familiar with is THC. Cannabis is one of the most widely used substances in Canada, with 42% of adults reporting usage during their lifetime. And as we all know, the Cannabis Act was passed in 2018, and this has complex social implications. But one thing that is true is that it has led to increased cannabis-related emergency department visits since legalization. And we see this in a lot of the states south of the border as well that have legalized cannabis in their regions. Interestingly, the first approved use of synthetic cannabinoids was to treat chemotherapy-induced nausea and vomiting. But we also know that with prolonged or heavy use, often cannabinoids can produce paradoxical pro-emetic effects. So a little bit about this interesting condition, cannabinoid hyperemesis syndrome. It presents as nausea, vomiting, abdominal pain, and it's often related to prolonged high-dose cannabis use. It was first described in 2004 by a large case series, a series of case reports, and then later the more formalized Rome-4 diagnostic criteria was developed. It tends to present in 3 phases. So you have your your prodromal phase, which can present as nausea, a bit of anxiety. There could be lots of autonomic symptoms, so sweating, flushing, malaise. And this prodromal phase can last for months before you enter the hyperemesis phase, which is the really more debilitating vomiting, and that's the phase also when you tend to respond to the hot showers and feel better with that. And then with cannabis cessation, patients may go into a prolonged recovery phase. But with ongoing use, they can go through cycles of this prodromal hyperemesis and recovery. This condition is highly under-recognized and frequently misdiagnosed. And it's obvious to see why, because you have to make sure it's nothing else. It's a diagnosis of exclusion in a certain way, and also it's often confounding with many of the symptoms of cyclic vomiting syndrome. So from a pathophysiology or toxicology lens, it's a very interesting condition. The exact mechanisms remain unknown, but we know that THC is a partial agonist of the cannabinoid CB1 receptor. And we also know that with high doses of THC, you get pro-emetic effects more, whereas with low doses, as mentioned previously, you can actually get some of these anti-emetic effects. Some of the proposed mechanisms are, I'll talk about a list of them in brief, although they're not well understood, but the most prevalent one is that with chronic high dose activation of the CB1 receptors in the CNS, there's actually desensitization and downregulation of these receptors, causing the entire endocannabinoid system to be dysregulated. These receptors are also implicated in your stress response. So with CB1 activation, you have inhibition of your HPA axis and sympathetic system. So it's thought that that may cause the nausea and vomiting as well. With chronic use of THC, a lot of the metabolites of cannabinoids, they accumulate. So after THC causes the high in the brain, with chronic use, they accumulate in lipophilic tissues. So they accumulate in your adipose tissue. And with time, they can slowly re-enter the bloodstream and can stimulate CB1 receptors in the GI tract, causing the nausea and vomiting. That's another theory. Interestingly, there's CB1 receptors in the hypothalamus as well. And at low doses, that's postulated to cause hyperthermia, but at higher doses, that can cause hypothermia. And people have wondered, is that why the hot showers work? Is it counteracting that mechanism? And then another one is the TRPV receptor signaling. So these are receptors that are located on the nociceptive neurons in the periphery on the skin. So people have wondered, is it a cutaneous steel phenomena where with the hot water, the blood flow is redirected from the GI tract, causing the symptoms to be better? Or is there some sort of interaction between the CB1 and TRPV1 receptors? The TRPV1 receptors, I should say, is activated by heat or other noxious stimuli. And it's often co-expressed with the CB1 receptor on the same cells. So is there some sort of interaction happening there? all this is very complex. And a lot of it may be theoretical, but lastly, genetic factors may play into this. So not everyone that uses cannabis has CHS. Not everyone has these reactions. So is there some sort of genetic underpinning for predisposition as well? So in terms of treatment, the only reliable treatment that we have to date is cannabis cessation, so completely stopping your use of cannabinoids. However, in acute care settings, many medications have been tried. So we have our dopamine antagonists, our 5-HT antagonists, antihistamines, anticholinergics, benzos, steroids, the TRPV1 agonists, such as capsaicin, which we'll talk a little bit more on in the rest of this presentation, as well as opioids. So this was a large review about the many types of treatments that have been tried. And it's small, but I hope you guys can see a little bit. So interestingly, your conventional medications for nausea and vomiting, such as ondansetron and metoclopramide, it doesn't actually work very well. So if you look here this is a compilation of studies, but ondansetron, 46 patients. Is that ondansetron? That's metoclopramide, sorry. 46 patients, only 4 were successfully treated. And ondansetron, 64 patients, only 4 were successfully treated. So not great. And this is related to the difference in pharmacology of this presentation. However, if you look at haloperidol and you look at lorazepam, they have been a lot more successful. So haloperidol, for example, 11 subjects, 9 patients were successfully treated. And then another one that's interesting on this chart is capsaicin. Out of 22 subjects that were treated here, all 24 were, all 22 were successful. And so anecdotal results appear pretty promising. There's also the aspect of side effects. So we know that haloperidol, being an antipsychotic, is associated with extrapyramidal symptoms and others, QT prolongation, etc. So it might not be as safe of a medication to use as capsaicin, which is available topically. So that seems very promising. Does capsaicin work? And we'll talk a little bit more about that. So capsaicin is a naturally occurring component of chili peppers. It's available as an over-the-counter topical analgesic. It's an agonist of this TRPV1 receptor, and it has a pretty favorable side effect profile. I mean, it does cause local erythema, skin irritation, burning, but relatively benign compared to other IV drugs, for example. Just a little bit of background literature for cannabis and cannabinoid hyperemesis syndrome. This TRPV1 receptor is a non-selective cation channel, as I mentioned, at the nociceptive receptors in the skin. So by using capsaicin, for example, and activating these receptors, you cause an influx of calcium and sodium, release of inflammatory micropeptides, causing transient burning, stinging, and itching. And it's thought that the mechanism is similar to that of hot showers, which also activate these receptors, as does heat and low pH environments. So that's how it's thought to work. There was a retrospective cohort analysis done for patients presenting with cannabinoid hyperemesis syndrome. And these patients were analyzed according to whether they had topical capsaicin as part of their treatment regimen versus whether they did not have capsaicin. The authors looked at the ED length of stay, as well as cost analysis, the use of rescue therapies in addition to capsaicin that was required to alleviate symptoms and any adverse effects. So in the capsaicin group, they found that the ED length of stay was reduced by a median of 22 minutes, although this was not significant. They found that 67% did not require any additional medication beyond the capsaicin. And they found that the total amount of medications, including opioids, was decreased. So that's certainly an important benefit. And they did not find any significant adverse effects. However, there's lots of limitations to this because it was a retrospective cohort. It was heterogeneous in that the concentrations of capsaicin used in these studies, it was highly variable. There was no standardized protocol for the other medications that were administered, like this conventional antiemetic medications. And they were given at different times. Also, a question I had was, is ED length of stay really a good measure of treatment effectiveness? All of these antiemetics are given through different routes, and capsaicin is topical, and although it's known to be absorbed relatively quickly, when the effect peak is highly variable, and we don't know for sure. So that brings me to my PICO question, which is, in patients presenting with cannabinoid hyperemesis syndrome, is topical capsaicin a safe and effective therapy for reducing symptoms of CHS? The population of interest is patients with CHS. The intervention is topical capsaicin cream. The comparison is placebo, and the outcome of interest is looking at reduction in nausea severity. So as I was going through and trying to answer this question, this relatively new paper was published in 2020, and it was a pilot trial of topical capsaicin cream for treatment of CHS. So the study design was a randomized, double-blinded, placebo-controlled trial in an academic urban center in the US with a large number of ED visits. The authors used the inclusion criteria of adults patients over 18 who was suspected to have an exacerbation of CHS and still had active vomiting or nausea by the time they presented to the emergency department. The authors excluded pregnant women, those with allergies clearly, those who have symptoms resolved, those who have used other prescription medications of antiemetics within the past 24 hours, other concerning conditions that weren't ruled out yet, and antiemetic medication in the ED prior to enrollment. So there's a caveat to this criteria because in the beginning, halfway through the trial, they were doing this. So if they got already a dose of ondansetron already in the ED, they couldn't enroll in the study, but they found that there was a lot of trouble recruiting patients that were super symptomatic. So this was changed in the middle of the trial, actually, where they said, it's okay, you can still enroll in this RCT if you've gotten a dose of something in the ED. So the treatment was applying 5 grams of topical 0.1% capsaicin cream to the abdominal area, and 0.1% is the higher end of the cream concentration. just to make sure that there is an effect. That's what the authors chose, compared to scentless placebo moisturizing cream. The ED doctors were able to make decisions about any additional antiemetic therapies that these patients needed. The blinding was done, and the treatment was provided by an emergency department nurse, but the physicians, the research teams, and the patients were completely blinded to what treatment they were receiving. They looked at nausea as the outcome using a visual analog scale that was already validated elsewhere. After application of the capsaicin or placebo cream, patients were directly observed for 60 minutes, and then they were followed up at the end of their hospital stay and at 30 days, just to make sure that they were not allergic and they did not have any adverse effects to the capsaicin cream or placebo. The primary outcome was the reported nausea at 30 minutes, and the secondary outcomes was reported nausea and change from baseline. Where these patients went, did they require admission, observation, or could they be discharged? And whether patients had complete relief of nausea and any additional need for antiemetic medications beyond having the capsaicin cream. So they screened 611 patients, was able to recruit 30, which were randomized, and all of the patients followed through in their allocated, the group in which they were randomized to. So just to make a comment about the protocol change that was midway through the trial, where they allowed patients to already have gotten some sort of antiemetic medication before enrollment. 3 patients in the capsaicin arm and 4 patients in the placebo arm received ondansetron 4 milligrams IV before randomization. Among the 30 patients randomized, the mean age was 32 years old, so very young patients, and 90% were African American. The capsaicin group also had a slightly lower baseline nausea score compared to the control group, although confidence intervals were overlapping. So 6 for the capsaicin group and 8.5 for the placebo group. The authors found that at 60 minutes, the capsaicin group had statistically lower nausea score, but their primary outcome at 30 minutes, there was only a trend. There was no statistical significance for a difference in nausea improvement. The percentage reduction at 60 minutes also showed superiority in the capsaicin group of 46% versus 25%. The capsaicin group, 29% of patients had complete resolution of nausea versus 0 in the placebo group. And also the capsaicin group seemed to require fewer rescue medications and required less admission or observation. It's worthy to note that 1 patient had immediate removal of the cream due to skin irritation. So the quick critical appraisal, were the assignments of patients randomized in the study? Yes. Were the groups similar at the start of the trial? In most characteristics, they were. However, when I looked at the baseline nausea scores, although the confidence intervals were overlapping, it seemed like the capsaicin group had a slightly lower score to begin with. Were the 2 groups treated equally? Yes, they were. They were observed very closely. Were all patients who entered the trial accounted for? Yes, there was no loss to follow-up at all. They were analyzed in the groups in which they were randomized, and the measures were objective. There was good blinding done, and only the ER nurse had access to the groups of the patients, knew what they were administering to the patients. And the treatment effect, it seemed to be significant at 60 minutes. And However, there were larger confidence intervals. So the strength of this study, it is the first randomized controlled trial to look at capsaicin for CHS. So that is exciting because in the past there have these kinds of studies always begin with case reports and then cohort studies. So this is a milestone. They really tried to focus on patient safety by that close 60-minute observation after administering the medication. So that was well done, although with the number of patients, it's hardly powered to detect all adverse effects. The blinding was done well, and there was no loss to follow-up. There are many limitations, however. As I mentioned, small sample size. The inclusion of patients was based on clinical suspicion for CHS. So there is a clinician dependent subjective component to acquiring these patients into the trial. As mentioned, there was a slight difference in how sick the patients were at baseline in terms of their nausea scores. And the treatment effect only became significant at 60 minutes rather than 30, so maybe not as rapid as expected. The authors met recruitment challenges, which required them to change their protocol mid-trial. So patients were too symptomatic to want to join this RCT. So imagine if you were vomiting and you had that bag held up to your face and you were being invited into a randomized controlled trial. Probably not great. So many of these people got treatment prior to enrollment, and that is a potential place of confounding depending on the antiemetic medication they got, although it was almost always ondansetron across the board. The other challenge that they met during recruitment was that lots of these patients didn't think that marijuana use was the reason for their symptoms. They did not accept that as their diagnosis. That was another challenge. And marijuana was actually legalized in this state during the middle of the trial, so that may have played a role. And lastly, there is as we mentioned, genetics may play into the pathophysiology of this condition. So with 90% of patients in this trial being African American, is there limited generalizability. So I just wanted to quickly touch on this other trial that's new in the field that just kind of sits next to capsaicin, offering other options. And I believe it was presented at toxicology rounds not too long ago, so that's why I didn't jump deep into this one. But it's called the HAVOC trial, also published at the very end of 2020, and it compared haloperidol against ondansetron, which is the conventional antiemetic treatment, which we previously have seen time and again, and in all the trials I've come across, not very effective for this condition. This was a randomized triple-blinded crossover trial that compared low-dose haloperidol against IV ondansetron. And the primary outcome was reduction from baseline abdominal pain and nausea 2 hours post-treatment. The authors found that haloperidol, even at the 0.05 milligrams per kilo dose, was significantly better than ondansetron in getting the effects, getting reduction in nausea and abdominal pain. Although also relatively small sample size, it's comparable to the capsaicin pilot trial. The effect was much more dramatic, and I would say it's no question that from the conclusion, ondansetron is not a good first-line antiemetic for the treatment of CHS. And so that leads to my question, just integrating the two trials. What if haloperidol or benzodiazepines are used instead of ondansetron as the pre-medication drug in the capsaicin trial, or used as the rescue drug? Would that have a better outcome for symptom relief. Would capsaicin still have an additional benefit? I would say yes, because they work in completely different routes of mechanisms of action, and there is no evidence whatsoever that haloperidol or benzos interacts with the TRPV1 receptor, which capsaicin works with. So just maybe food for thought for future trials. So just a quick clinical bottom line. Capsaicin is emerging as a promising therapy, although very limited evidence from this pilot RCT. We need more data with a more diverse population for the results to be used across the board. In these trials, often we talk about clinically favorable trends being more important than statistical significance, especially when the sample size is so small. And the benefit that I see with capsaicin topical treatment is that it's available, it's low cost, and generally it is deemed to be quite safe. We see that there is great potential for it being a outpatient therapy, especially I think among patients who may not necessarily recognize that their THC use may be a possible cause of their symptoms. A lot of patients will say, no, I think it's something else. I think we're missing something here. We need to do more CTs or more tests. I don't think I use enough for this to be the reason. And these patients may prefer to be much more autonomous with how they manage their own health. They may not like being told that this is a problem. So giving them something that's relatively safe and that they could use on their own, that works in a similar mechanism but is safer in many ways compared to the hot showers, may be a way to give them more sense of control and ultimately help these patients with their symptoms. So these are my references. Thank you for listening, and I'm happy to take any questions.
Thank you, Kate. We currently just have one question in the chat from Ken Doyle asking if there's any evidence on the role of ketamine or potentially even Haldol plus ketamine. Did you see anything on that?
I have not seen ketamine. That's interesting though. I mean, it would have the analgesic effect, I would expect. What mechanism would it do that? I'm not sure. I'm gonna look into it now. Has anyone else come across ketamine as a potential treatment option? Feel free to jump in.
Obviously, I've never heard of it being used for anti-emesis, but
right.
I'm sure somebody's tried it, right? People have tried ketamine for everything.
Yeah, people have tried propofol for everything, so yeah.
Okay, I don't know if anyone has any other comments, but any other thing they've tried or used?
I just have a question. Hi, Kate. Thank you so much. This is super interesting. You probably mentioned it. I'm so sorry for that. But the capsaicin topical, where exactly do you put it, and how much do you put of the
so
for it to be effective? Yeah.
Right. So in the trial, they did 5 grams, and just in a thin layer. They did it mostly over the abdomen, the anterior abdomen, like the epigastric area. But there have been trials that also have done it on the arm, etc. I think the most common one is the belly. And you can do that. The thought is that the capsaicin cream is absorbed very rapidly, that the peak effect is somewhere between 30 and 60 minutes, and you can repeat the application up to every 4 hours.
Awesome, thanks.
There's a comment from Monica Chemignani pointing out that when you give Haldol, you should advise people of the potential effect of dystonia.
Yes, of course. Yeah, the thought in the Havoc trial is that because it was the 0.05 milligrams per kilo, they thought that risk was very low, but certainly like very unpleasant reaction that everyone should be aware of. Thank you.
Okay, so I think that's it.
I just have a question, sorry.
Oh, yeah, of course.
Just wondering if you looked at other antipsychotics, specifically second gen, that potentially have less effects, like olanzapine, for example. I've seen a little bit. Any like head-to-head trials on which antipsychotic is better?
I don't think I have seen any RCTs on this because the Haldol is so new. It was published in December, I believe, of 2020. I know that Haldol is unique in its own family in that it has sedative effects, which actually in this case benefit the it treats the nausea and the abdominal pain in a way that other antipsychotics, even in its own family, does not. But the pharmacology there is very kind of new and not well researched at this point. But that's a good point. Those are additional therapies for sure that could be tried. I don't think I came across olanzapine as much as I did Haldol. For what reason, I'm not too sure at this point.
Thanks.